Hey, good video. Well, guess what? Coloring. David.
Hi everybody. Can you hear me?
So look like it's just you and I.
Thought I saw a couple other people.
I just saw Asia, but then she left off.
Uh, yeah, yeah. Looked like she signed on. Um,
The only person I saw come on.
Miss Cargill didn't come on.
I don't know. Let me text her and see what she's doing.
I thought she had joined, at least momentarily. Well, I thought I sent the email out timely enough, but I guess that depends on, you know what? In fact, let me text some people too. Text.
Hey, good job. Get out of there.
I think I am recording just in case. Maybe people are working.
We'll be able to listen to it later.
I hope so. I don't do Zoom a whole lot. I normally do a Teams, so I should have probably
Jenna,
sent you guys a Teams meeting instead. But I
Jenna
do.
said she's working, babysitting. Clay
Who?
said he's at work, but he's gonna try to cook. Jenna, she's babysitting.
Oh,
Clay said he's at work, but he's gonna try to listen in.
hmm.
Um,
Yeah. Well, like I said, I should be able to record it and send the link out, just in case people, you know.
there's Kayla.
How you doing, Miss Baki?
And why you gotta be saying my life?
Yeah.
Why you
Uh,
say it so hard? What's wrong?
just like Miss Joan Baptiste. I mean, you got
Whatever.
got to put a little emphasis on these names. Wouldn't be appropriate. I almost want to just say Miss Baptiste, but I mean the Joan is part of the name, so
Why you just don't say Tanya?
I like Joan Baptiste.
Okay.
Hmm. Um. Hmm. All right. Anyway, so I guess they'll join if they want. Otherwise, I guess they
Yeah.
got it, right? So what kind of concerns do you guys have in particular?
Personally, me, I'm getting pretty much all the chapters. Like I have a cool understanding for. Are we talking about adult nursing or pharmacology first off?
This is Pharm because remember, there's a Pharm exam on
Okay,
Tuesday.
Tuesday. Yeah.
Yeah.
So I'm pretty much I got all the chapters down packed, but what I'm not understanding, I done read the chapter, I done watched 20 million videos, I done drew on my little whiteboard, I done did everything I possibly can think of. I've been doing like Quizlets and like Kahoots and stuff and note cards and flashcards for the muscular skeletal system, and I'm just not my head is just not wrapping around it. I don't know what not getting. I'm not getting it. I don't know.
Can you be more specific? I mean, if we are, what chapter are we talking about?
I believe that's chapter 29 if I'm not mistaken.
It's 29.
20.
And like all the other chapters I'm getting, like I have it down pat. That's fine. It's perfectly fine. But that one particular chapter with them drugs, I don't it's not clicking in my head for some
But
reason.
29 is a real short chapter, but the drugs, yeah.
Yeah, I'm just not it's not clicking in my head.
Did we talk about this in class? Drugs.
Yeah. We talked about
I'm trying to remember, when did we talk about this?
Let me
I think
see.
we went over that week 7.
Week
Week
7.
7. I think we went over it week 7 or week 8. I can't remember, but it was one of the two.
Hmm.
Let me see what I have as far as the notes. Yeah, I think I left my
Let me
other.
see something, because for some reason, see, that's 152, and you said 29. So yeah, so that would, you guys are testing. All right, I see it. Chapter 29. I guess we go over so much, you kind of forget what it is we did. Um, all right. So let me show you what I have. All right, so let me go ahead and share this. You still may have to be a bit more, um, you know, specific in terms of what you are having difficulty with. So one of the drugs in this particular chapter is the skeletal muscle relaxants. Right.
Oh,
So, and I got the notes pulled up too. But let me see something.
Cause I think for me, it's more so of like the Kara oh, I don't want to. I cannot say this. I don't want to play today. The Carisoprodol
Hmm.
and the cyclobenzaprine, benzapran. I don't know how you say that.
Yeah, the
mm.
the cyclobenzaprines. All right.
Yeah.
All right. So one of the things we have to understand about these drugs is obviously why we are giving them. And this will, of course, we have to start thinking about the med surge piece to this. All right. And so when these patients, when they sustain injuries, their muscles begin to spasm. And as you all should know by now, spasms can be extremely painful, right? And so what these drugs are basically doing is relaxing, hence the name skeletal muscle relaxants. And it's really the muscles that we're trying to relax because that is what is where the spasms, if you will, are coming from. All right. So so then it does become a kind of pain reliever, but only in the sense that it is decreasing those painful spasms that are occurring due to the like a sprain or a strain or something like that. All right. So here it talks about, see, so in addition to pain relievers, skeletal muscle relaxants are used to assist in relaxing certain muscle groups in terms of strains and sprains. Um, let's see, skeletal muscle are used to assist in relaxing certain muscle groups as strains and
I
sprains.
do have one specific question though.
All right.
So when it comes to the diazepam, what? I don't know how you say it.
This
When
one.
it comes, yeah, the volume. When it comes to the volume, what would be the specific case as to why I would give them Valium instead of like Car or baclofen or the Carisoprodol or whatever? Like I don't.
Well, I mean, this drug also helps to relax muscles, although they primarily is given as an anti-anxiety drug. But some of these drugs, they also help with other conditions, even though we may not know how or why, but it does. And having that knowledge, we basically treat it with that particular drug.
I
So.
think that's what I remember last quarter that like when she mentioned diazepam, I remember there was a question or there was something about, which disorder is that used more with? I think, and I remember that one more so because of cerebral palsy. They were talking about that one. So I think in this one they were talking about in the musculoskeletal chapter,
Mhm.
they were referencing which drug would be used for which disorder.
Right. Well, and you guys already know that when you think about your objectives, do tell you that you should know the uses. All right. And I think that's pretty easy, y'all. I mean, it's just a matter of doing flashcards. Because some of this is memorization, but as I've often told you all, try to stay away from memorization as much as possible. But that as much as possible doesn't mean stay away from it completely. It just means that wherever memorization comes in at, you use that, and wherever comprehension comes in at, you use that. Now, if we're talking about how the drug works, like the mechanism of action, we're talking about comprehension, right? But if we're talking about what drugs are used for what, then it's pretty much a memorization type of skill that you have to have, if you will. All right. So, so in this case, where it talks about the exact mode of action of diazepam or Valium, which is an anti-anxiety drug, and the relief of painful musculoskeletal conditions, is not known. We don't know the mechanism of action. And that's the way it is in some drugs. With some drugs we know the mechanism of action, and some drugs we don't. You know, and so you're not expected to know something that there's no answer for, if that makes sense. All right. So I don't know how a question would be worded like that, but if they were to ask you a question about how does the drug work, I mean, I can't even see them asking you that question because your textbook says that we don't know how it works. So why should we ask you something like that on the question? What you should know, of course, is that this is a drug that is used for that particular condition. Um, they do talk about how the drug does have a sedative action, which may account for some of its ability to relieve muscle spasms and also pain. So the drug could just cause people to want to or to relax basically. And when you're relaxed, you're not as tense, and so the muscles are not as tense. And if the muscles are not as tense or spasming because you're more relaxed overall, then that'll decrease the pain also. So see
Thank
the
you.
so the mode of action of many musculoskeletal relaxants, such as these mentioned here, is not clearly understood. So even these are not clearly understood. Many of these drugs do not directly relax skeletal muscles, but their ability to relieve acute painful musculoskeletal conditions may be because of the sedative action. So here again, it's not a direct effect on the muscles that are spasming, but it just causes the person overall to just be able to relax. All right. So like this is what do they call this? They order for people all the time. Cyclobenzaprine. I can't think of let me see something. Uh,
What was the question you were talking about?
this drug here, there's another name for it. That I just couldn't think of the name. Flexeril. You guys have heard of Flexeril because they order it when you have
I have.
huh? They
Yes, I have
yeah,
Flexeril.
yeah, they typically order it for you when
Hmm.
let's see, where was I? When you have back pain, lower back pain, because when you have low back pain, you say, well, where does the pain come from? It's because the muscles surrounding the spine are spasming, and that's where your pain comes from. So they give you these muscle relaxants that causes a kind of a sedative effect. And this is why one of the big things about this drug is that you don't want patients operating heavy machinery, driving and otherwise, because it takes away your alertness because of the relaxation effect that it has. And so basically, this particular drug appears to have an effect on muscle tone, thereby reducing the muscle spasms. And so, again, may not know exactly why, but if it causes this overall relaxation, that could be the reason why the muscles are then less tense. All right. And of course, if they ask you what disease conditions do you use this particular drug, basically muscle strains and back pain, which is what I just talked about. When you have back pain, a lot of times it's because of, spasms. And so we're basically relaxing, those spasms, the muscle tension, if you will. Let's see, sedative action that relieves acute painful musculoskeletal conditions, affect the muscle tone, reducing muscle spasms. So it just basically, probably not directly, but just making the person relax helps to relieve those spasms as well. So that's the skeletal muscle relaxants. I think they're like four of them. Let's see. And so, if it has the muscle relaxant of this overall sedative effect, I mean, you can see here that all of this makes sense because you have it's kind of depressing things, right? It has a more depressant effect, drowsiness, sedation, sleepiness, lethargy, and so forth. It's kind of slowing things down. All right. Let's see. Just trying to see which all the different ones here. Uh Skeletal muscle license. All right, and this is another one here. Was there a voiceover on this, or did I actually go through this? For some
I
reason,
don't think you did a voiceover on this.
There wasn't a voiceover, if I'm not mistaken.
there wasn't.
No, not that I remember. No.
Man, we must have did this so.
Only do voiceovers over the shorter chapters.
Yeah, yeah. For some reason, I just don't understand. All right. Now, so the DMARDs, this is another group of musculoskeletal drugs. So it's a disease-modifying anti-rheumatic drugs. All right. And so you have to think about like your rheumatoid arthritis, which is an autoimmune disorder. And it produces immunosuppression, which decreases the body's immune responses. And so you guys know that with rheumatoid arthritis, it being an autoimmune disorder, that basically it is destroying the bone tissue, if you will. And so, as with any autoimmune drug, wherein the disease itself or the body turns against itself, well, we're trying to lessen or weaken the immune system so that it doesn't continue to destroy bone tissue, if you will. So here, think about this. So rheumatoid arthritis, being an autoimmune disorder, as I say, you all know what that is. And this is when there are antibodies that are formed against one's own body. All right. We know this. As a defense mechanism, white blood cells are mobilized and lodged in the joints. So whenever whenever the immune system is activated, which your white blood cells is a part of that, they're going to, in other words, become more mobilized and they travel to those joint areas. And when they get within those joints, right, that inflammation is causing, it causes swelling, pain, as well as inflammation, right? That's basically rheumatoid arthritis. So this condition is typically treated using three classification of drugs. So they use the NSAIDs. We know about NSAIDs already, but it also uses corticosteroids because of the inflammation. but also it uses these drugs, the DMARDs. And you guys already know what these drugs do. So DMARDs are kind of a new, well, we're introducing something a little different in terms of how we manage these musculoskeletal conditions. Now, early stages of the disease process may respond well to NSAIDs by itself. So they may be just treating it initially or in the early stages with the NSAIDs. Again, we understand what happens with NSAIDs and how it relieves pain by reducing inflammation. But now, when the rheumatoid arthritis becomes worse, pain medications and corticosteroids may be used for quick relief, right? But the DMARDs are used to actually suppress the immune response. Now, of course, with corticosteroids, they also really have they suppress the immune system as well. So both of those drugs are acting rather similarly in a sense in terms of suppressing the immune system. But the DMARDs in particular, they're more specific to suppressing the immune system that is actually attacking someone's joints. All right, so here, I just kind of like to go through it so that when you guys try to read it yourselves, it'll hopefully make more sense. In terms of action, so the mechanism of action. So when the immobility and pain of rheumatoid arthritis cannot be controlled by the pain relief agents like the NSAIDs, and also even the corticosteroids, then this is when they are going to move to this particular drug. All right. So they'll try the NSAIDs, they try the corticosteroids, but sometimes the condition it actually gets worse. So the most commonly used DMARDs are your methotrexates, the sulfasalazine, the hydroxychloroquine, and also your leflunomide. Actually, let me put that in red. So hopefully you guys are making cards for these as well. All right. So these are going to be your immunosuppressant drugs. Remember, the antibodies of this person's body is destroying its bone tissue, joint tissue, if you will. So we need to calm it down. We need to quiet it down. We need to make it more weaker so it doesn't cause more destruction. All right. Now, these drugs have properties to produce immunosuppression. All right. These drugs suppresses the immune system, which in turn decreases the body's autoimmune response. And that's what we're trying to do. That's the goal. That's the goal for these drugs, is that they decrease that autoimmune response, that autoimmune, again, the body's attacking itself. All right. So in rheumatoid arthritis treatment, these drugs are useful for their immunosuppressive abilities. They have the ability to reduce, to lessen, to weaken the immune system, basically. All right. Now, it also talks about how other conditions are treated with these drugs also, because they are autoimmune diseases. So these DMARDs can be used to treat Crohn's disease as well as fibromyalgia as well. Now, this drug here, this methotrexate, which is a DMARD drug, is used in cancer therapy also, in which the immune suppression is considered an adverse reaction rather than an intended effect. All right. So basically what we're saying here is this. So in simple terms, this drug, this methotrexate, that is used in cancer treatment, right? So we use it in cancer treatment. And what happens is it works by slowing down the growth of cancer cells. So we can use it for that purpose too, for cancer, trying to slow down the growth. We're trying to make sure that the cancer cells do not multiply. One of the results of using this drug, of course, is that it weakens the immune system, right? And of course, when you weaken someone's immune system, it's going to be very difficult for them to fight off infections. All right. It can also bring about other cancers if you think about it, because the immune system, when it's adequate, it prevents cancers from occurring in the body. But this drug is going to weaken the immune system because we're really trying to fight the present cancer that this person has. See, these these are the ones who already have cancer, and we're just trying to stop the multiplication of the cancer. All right. But, I guess you could say that a side effect, if you will, is that other cancers can come about because we are um, making the immune system rather weak. And the immune system should never be weak, but depending on the type of conditions that we're dealing with, it may be the only thing, the only choice, a treatment that we have. So while this is a side effect or something unintended, it does help to slow down the cancer. All right. So that's a good thing, right? All right. So in cancer therapy, the drug's ability to weaken the immune system is considered an unfortunate but necessary treatment for cancer. Right. So that's one of the other uses, again, for the methotrexate. Again, similar drug that we also use, or the same drug we also use in the treatment of rheumatoid arthritis. And so, with drugs like this, I mean, you guys have to do a lot of patient teaching the patients to not go around crowds or sick people, washing their hands. They have to. We're concerned about them developing other infectious conditions and whatnot. Again, because we are weakening the immune system. All right. So, so in this particular area, although our main discussion is about, the autoimmune disease as what we speak to rheumatoid arthritis, but here is also talking about some other conditions, in other words. So there's a bit of a switch here in terms of what we're talking about. So there are also drugs called tumor necrosis factor inhibitors. And they also use these drugs in people who have rheumatoid arthritis and also other inflammatory conditions. All right, let's see. Trying to think where this fits in. So the tumor necrosis factor is a small protein that regulates the body's immune cells and produces inflammation. All right. And of course, we know that inflammation is the body's natural defense mechanism that helps us to heal, and it protects us. But so this is something you guys don't really need to get too deep into. But when we're talking about this TNF, this is all a part of the immune system. And we know that the immune system brings about a kind of inflammation. And sometimes this inflammation is just too much for the body. And if it begins to destroy our own bodies, we need to do what? Inhibit this inflammatory process. Hence the reason we refer to it as inhibitors. We're trying to inhibit this inflammatory process, this tumor necrosis factor. It's an inflammatory process, and it regulates the immune system or produces inflammation. Sometimes we don't want that inflammation, all right, because it has a lot of damaging effects. Now, these inhibitor drugs are also termed biologic DMARDs. So we're back at the DMARDs, and it works to suppress the body's immune response. And so that's what you just need to know is that these drugs are just basically we're trying to rather suppress the immune system because the immune system is causing a lot of damage. Sometimes the immune system just does too much. Right. And what we're trying to do is control it better. All right. Now, some of the biologic DMARDs are listed here that you can see here as well. I don't know why I didn't do that one. All right. As you can see, the drugs here for these biologic DMARDs. All right. That's all I'll say about that. But do you all get the gist of what I'm trying to explain to you here?
Yes.
Yeah.
Yeah.
Yeah, it's just an an inflammatory, an autoimmune situation here, and we're just trying to, we're saying, hey, calm down. You're doing too much. You're causing too much destruction, you know, and whenever you think about the immune system, think about it along those lines. The immune system it does great things. I mean, we need an immune system, obviously, but sometimes it just does too much. It causes too much destruction. And that is not what we want. Well, we want it to do its job to a certain extent, but if it goes overboard, we need to calm it down. And that's why we use anti-inflammatories or immunosuppressants and so forth. All right.
So in this chapter, just be focused on joint pain, immunosuppressants. I mean, that's pretty much what I got from the chapter, recognizing, how to react to those, the different pains, which medications will work and for whichever disease process it is. And how they affect with the central nervous system. I think that's pretty much it.
Well, I mean, so far, kind of if kind of look at it from the standpoint of like we started with the muscle relaxants. You guys understand that. I hope you see what a lot of the drugs are doing. Not much in the way of what we discussed so far of any direct effects on the skeletal muscle, but that overall sedative effect and whatnot, and is causing more relaxation and less muscle spasms and so forth. But now, when we jump to these particular drugs, we're talking about autoimmune disorders and how we're just basically suppressing the immune system. And we know what comes along with that because if we go through the rest of this, so you will see responses that are due to the suppression of the immune system. So, for example, biologic DMARDs produce flu-like symptoms because they reduce the immune response. So infectious diseases such as tuberculosis are a concern. Why is it a concern? Because if you're suppressing the immune system, it can, although you may be treating let's say, the rheumatoid arthritis, now you're welcoming other problems.
Infection.
Hmm?
You're more prone to infection than.
Yeah. Yeah. You have other problems now. So it's like, well, why do they do that? See, I know, so probably in your mind, you're thinking, well, why would they do that then? Well, it's kind of the risk benefit kind of ratio, risk versus benefits. So they're probably a little more concerned about the benefit of alleviating or reducing the pain that these patients are experiencing is what we are more concerned about at this point. Now, at the same time, we can also be vigilant and watching for other infections that may come about. So for example, if I know someone has a history, which is why we take histories from our patients, someone tells me, say, I was exposed to TB, so my PPD is positive. So I know if I put a patient on one of these types of drugs, then I'm going to instruct the patient to be what can I say? I want them to be aware that they may end up developing TB. So look for the weight loss and the anorexia and the night sweats and the hemoptysis and all these things. It's because I'm impacting their immune system. So, in other words, we need to do this treatment because otherwise the patient's mobility, if they have rheumatoid arthritis and they're in so much excruciating pain that they can't really move or walk, which now creates another set of problems. You know, those movement disorders. Now you're set up for pneumonia and muscle atrophy, and your muscles become more contracted, and again, the atrophy sets in, pneumonias, and so forth. So we can't have that either. So you give them these drugs, and even though they may provide relief, they also bring some other problems that we just have to be aware of. All right.
Dr. Weaver,
Yes.
would DMARS be given for a long-term treatment?
You know, so we're talking about rheumatoid arthritis, and I would imagine that as long as the disease, it's a chronic progressive disease, number one. So they may continue it for a good while, but maybe at lower dosages. And for how long, I would say perhaps as long as they have the condition and as long as it's continuing to get either worse, or maybe even if it is responding positively to the drug, then they may be able to just place this patient on a more maintenance dose, right? So you don't have to keep jacking up the dose as we go on. But let's say if the max dose is 50 milligrams, and I'm not saying it is, but I'm just as an example, the max dose is 50 milligrams, but I'm up to only 5 milligrams, and that 5 milligrams is doing the job. Well, I can just keep them there. Otherwise, I have to keep titrating 5, 10, 15, 20, and so forth until I get this condition under control. So I would say it just depends on how the disease process is responding to this drug.
Okay.
But check it out. So the adverse reactions to sulfa-based drugs such as sulfasalazine include ocular changes, GI upset, mild pancytopenia. Again, because this drug is impacting the immune system. Let's see. So those are your DMARDs. Methotrexate. All right. Just trying to see what are the other ones. So these are your DMARDs still. All right. The next one is your bone resorption inhibitors and your bisphosphonates. All right. So one of the reasons why, of course, I did provide this piece of information here is to help you to understand why this drug is important. So it talks about the number of people in this country who are suffering from osteoporosis or a low bone mass. So they have a low density a bone mass. So we have bone loss in these patients. And of course, those who are especially susceptible here are postmenopausal women. Because the bones are so porous and weak, it does lead to spinal fractures, hip fractures, and a lot of it, of course, because of this condition. And so the bisphosphonates and the newer biologic drugs are helping to reduce these fractures. And so obviously they're making it so with the bones, helping the bones to grow, to become stronger. All right. So they act primarily on the bone by inhibiting normal and abnormal bone resorption, resulting in increased bone mineral density. All right, decreases or inhibits osteoclast. All right. So when we talk about osteoclastic activity, we're talking about the breaking down of bones. And so what these drugs do is they prevent the osteoclast and they promote osteoblast. Remember, the osteoblast is the building up of the bones. All right. So your bisphosphonates, again, they act primarily on bone by inhibiting normal and abnormal bone resorption. When we're talking about bone resorption, basically how the calcium is essentially leaving the bones. The more calcium leaves bones, the weaker the bones get. All right. So, but if I can inhibit this process, the result is an increase in bone mineral density. So it makes the bone stronger. It adds more calcium, if you will, to the bones. All right. And so if we can prevent bone resorption and improve that osteoblast, then we're basically not only building new bone, but we're adding more calcium to the bones. We're making it more stronger. And then, of course, these patients they don't have to suffer these hip and spinal fractures and what have you, if you will. Now, check it out here, what I wrote here for you. So bone resorption is the process where specialized cells called osteoclasts break down bone tissue. And so this is what's happening. Bones are being broken down. And just remember those terms. They could test you on them. Osteoclast means breaking down of the bones, right? Now, during this process, the bone's mineral content, especially calcium, is released into the bloodstream, right? So this calcium, I believe phosphorus as well, they're leaving the actual our actual bones, right? And remember, calcium, phosphorus, it makes our bones strong. But if they're leaving the bones and being released into the bloodstream, then it's making our bones weaker. So this is a normal part of bone remodeling, which involves a balance between resorption, breaking down of old bone, and formation, the building new bone by osteoblasts. So what they're saying to you is um, this osteoclast and osteoblast, this is normal, right? But you can have more osteoclasts and very little osteoblast. You can have more bones breaking down, right? And less bone rebuilding because the end result would be weaker bones. So you want to have a balance. Remember homeostasis? So basically, yes, bones are being broken down through this process, but we're also rebuilding bone. And so that gives us stable, strong bones. Does that make sense, everyone?
Mhm.
Yes,
All right.
we need both.
We
But
need both.
hmm
We need both. You can't have one without the other, right? We need both. Now, if bone resorption outpace, which is what I just said, I didn't even read this, but it just has to make sense, people. If bone resorption outpaces or is more than or is greater than bone formation or osteoblast, it can lead to decrease in bone density, which contributes to conditions like osteoporosis. Now, some of the older, now I'm not saying this to throw shade, but some of you young women, you don't know too much about osteoporosis and the risk, that you're at because of, what is it, menopause and so forth, right? But depending on your age, you understand this because you have to go to the doctor. You got to have these bone scans done, and they have to check your levels to see if you need to go on calcium supplements and so forth. And But this is something for you to look forward to. In other words, if you live long enough, right? So, do you guys understand what these drugs are doing? The bisphosphonates,
Yeah, they
right?
on inhibiting bone reabsorption.
This bone resorption, and check out the term, it's bone resorption. That's different from bone reabsorption, but it's bone resorption. That could be a tricky term, right? That can be a tricky word there, but it's actually bone resorption, not reabsorption. It's easy to get the two mixed up. All right. And so, of course, your bisphosphonates are used in the following. So it's used to treat osteoporosis. That should be easy for you to recognize. All right. Do your cards. And postmenopausal women and men caused by glucocorticoids. So when people are on glucocorticoids, and this is something that you want to keep in mind too,
Mhm.
people who are on glucocorticoids, they also can develop osteoporosis, even men. Because take a look at what glucocorticoids, steroids, look at what they do. So glucocorticoids reduce the body's ability to absorb calcium from the what?
From the bone,
From the intestines.
from the intestines.
You guys see that? You all see what I'm showing you, right?
Mm-hmm.
Or is it not big enough or what?
It's there.
All right. So, all right. So when we think osteoporosis, we think about just women. But if, let's say if I have asthma, and I'm on a glucocorticoid, one of these steroids, or I'm on the steroids for whatever condition, other condition that I have, and it prevents calcium from being absorbed in the intestine. As a man, I too can develop um, osteoporosis. So it would be for men and women, right? So don't get tricked on the test. Depending on how they ask the question, it could be situation where you say, oh, yeah, women, pick that answer. But if you did your readings, you would understand why men also can be involved. We don't go into menopause.
So osteoporosis can happen to both genders, is what you're saying?
You see that, right? You see that? But do
Okay.
you understand why is the question?
Well, I'm sorry, can you explain a little bit more, like why men can get it too?
All right, all right, I want you guys to read this and you tell me what I
Okay,
just highlighted. You tell me why.
okay.
So the body is decreasing its ability to absorb the calcium from the
And what
intestine.
happens if you can't absorb calcium? You tell me what happens.
Then you'll
And
have
Your bones, yeah.
They
bones.
develop what?
Osteoporosis.
Period.
Okay.
Period.
That's what I keep telling you. Look, guys, all you got to do is read it. Just read it. You guys have the ability to read this information. It ain't hard.
You're right, Dr. Weaver.
Sometimes you just don't take the time to read it. Don't be so dependent on somebody to open up everything to you.
Yeah.
Be an independent thinker, independent learner, and go after this information more aggressively. You can do it. This is plain, isn't it? Look how plain that is. Come on, people.
Yeah, it's plain.
Now maybe you guys got a little caught up on glucocorticoids, but you know that's a steroid
Right.
because of what we've studied before. We've studied this before. And so that's a given. Now check this out. Now, I will tell you this just right off the top of my head because of knowledge I've always had with this is that if somebody ever comes into if they come to the doctor does labs and they notice that the patient's calcium levels are very high, there's a great likelihood that this person has cancer.
Mm.
Because let's say if you have breast cancer and then it metastasizes or spreads to your bones, and then it begins to break down your bones, what do you think that calcium is being released to?
mm,
Into what?
that's what you just read. The intestine.
Intestines.
Gets into the bloodstream, right?
Mhm.
when it's reduced, released.
It's releasing if releasing to the bloodstream, and that's why you have high calcium levels because that cancer is destroying the bones. So
Oh, so when it don't have the bones to go to, it just gets released throughout the body, and that's what gives you high calcium levels.
yeah, see
Okay.
hypercalcemia, increased serum calcium of malignant diseases and bony metastasis of some solid tumors. So basically,
Because the
there's some,
calcium is going into the bloodstream.
yeah. And so when I test that blood, and I do my labs, say you come in with some condition, so remember when we talk about hyperkalemia, hypokalemia,
Mhm.
hyponatremia, hypernatremia? Well,
Hmm.
they are symptoms of hyperkalemia, hypercalcemia.
Hmm.
All right, let me show you what it looks like. All right, so bear with me. All right, I didn't want that. Wait a minute. I just want to give you a feel for what I'm talking about. So if I said signs and symptoms of hypercalcemia, right? So someone comes into your medical facility and they come in with these symptoms. So here are, let me see if I make that. Can y'all see that?
Yes.
Somebody comes into your facility complaining of fatigue and weakness,
Mm-hmm.
gastrointestinal issues, nausea, vomiting, constipation, urinary symptoms. You're a great clinician and you're listening to what your patient is saying. You're talking about the symptoms and neurological effects like confusion, impaired concentration, memory problems, cardiac issues like an abnormal rhythms. They're coming to you complaining of all these things, right? Your doctor is going to do some labs on you. In particular, they're going to do, not likely, they're going to do a BMP, a basic metabolic profile to look at your electrolytes. Calcium is an electrolyte, even though this calcium is coming from the bones, because the bones are breaking down from the cancer, it is
Mm-hmm.
still an electrolyte. And so when I check your labs, I'm going to see hypercalcemia. And I will tell you that as a clinician, I'm going to likely say, does this patient have cancer? Because it may come from, for example, if you got breast cancer, lung cancer, especially prostate cancer. Um, Cancer typically spreads to the bones, and that cancer is eating up the bones, or I'm saying eating up, sort of layman's, but it's causing destruction to the bones. They're breaking down and they become weak. And they become these patients develop a kind of osteoporosis as a result because of all that calcium is leaving the bones.
Dr. Weaver, would that also affect the white blood cell count too, or is that something different?
I don't, well, I mean, if we're just talking about the cancer in and of itself, it can affect, your white blood cells and platelets too, possibly, and red blood cells. But um, here, unless you're seeing something in terms of symptoms, um, yeah, I don't see anything in terms of what that hypercalcemia would result in, um, that it would result in what you just said in terms of affecting white blood cells. I kind of blocked
Okay.
it. Yeah, so no, I don't see anything that speaks to that. But check out how they talk about by reducing osteoclast activity, the bisphosphonates lower the amount of calcium released from the bones, thereby helping to decrease high serum levels of calcium levels. In other words, with this particular drug, I'm reducing that destructive activity, that osteoclast. I'm inhibiting that. If I can inhibit that, meaning I'm making the calcium stay in the bone. That's what this drug is doing. And if it helps the calcium stay in the bones, when I do blood levels, the blood levels are not going to be that high. It may be high, but not that high. Or they may be normal. As long as this drug can prevent the calcium from breaking down and entering into the bloodstream. So as you guys know, they ask you these questions. They ask you that.
So, Dr. Weaver, hopefully this makes sense. So with these particular drugs, are they given as like if somebody, like if a woman's going through menopause, is it something that's given like prophylactically, or is it just something that the medication they give when a person has osteoporosis? So is
They're
it given as a preventative or, you know?
They do prophylaxis. I mean, they may tell a woman to take some extra calcium, some vitamin D, because just kind of heading off or anticipating that she may experience osteoporosis, because it's just one of these physiological um, responses, normal aging responses that women go through. So yeah, it wouldn't be far-fetched to treat it prophylactically. And of course, you're going in periodically. You have your bone scans, or what is it? What is it? The DEXA scan. Is that what it is? Anybody remember that?
T-scan.
Yeah, it's the DEXA. I think it's the DEXA.
Yes, the DEXA scan.
Yeah. So, and so you have this follow-up, and depending on what that says, it may say that, your bone density is not all that great, or, you appear to be losing maybe some height, maybe it's showing something abnormal. So let's put you on some calcium and some vitamin D, and make sure you're walking, and because that also strengthens bones and it causes more calcium to stay in the bones and make them stronger as well. So there's different things that we can do to improve this. And you'll probably see some of this in the nursing process, where it gives you different pointers, if you will. Um, so how do you all feel about this one?
I feel a lot better about it because I had questions about this chapter too. So I'm glad you guys were already doing it.
Yeah, yeah. So those are your bone resorption, not reabsorption, but bone resorption inhibitors. In particular, your bisphosphonates. All right.
The
So
body needs calcium to remain in the bone, not in the bloodstream.
we're trying to
Blood,
keep them in the bone.
right. So calcium in the bloodstream can lead to cancers.
Now back up, say that again.
Calcium in the bloodstream can lead to
No,
cancers.
Nope. Let me stop you. And see, this is good, because when you all are speaking it out, and if I'm really listening, and if there's errors in thinking, and this is nothing bad against you, so hopefully you're not offended.
Oh, I didn't think of
But
that.
I want to be able to correct the way you're thinking. So what I'm saying to you guys is that someone may have cancer. Let's say if someone has lung cancer or breast cancer, right? Or cancer anywhere, and that cancer metastasized. It metastasized to other organs, one being the bones. So now you have also bone cancer. Cancer has a way of destroying the bones. And when it destroys the bones begin to release calcium into the bloodstream, which we'll know by getting labs and whatnot. That will alert us that if you got all this, if you have all this calcium, your calcium level is a 13.5. And it isn't supposed to be that high. It's supposed to be, I think, on the high end, maybe 9 something, right? In terms of the range. But if that calcium level is like a 13.5, I'm thinking, uh-oh, what's going on? Is there a cancer somewhere? So then I start doing these scans and I'm working you up. I'm trying to figure out, I'm doing breast examinations or mammograms and CT scans and PET scans. I'm doing all these scans, all this blood work. Then I discover, I'm sorry to tell you, but you have breast cancer, stage 3 or 4, meaning it has what? Metastasized.
So hypercalcemia levels complicate cancers.
Well, it can complicate it, of course, but it also makes us to know that something else is going on.
Okay.
Yeah, it makes us to know something is going on. You know, these labs tells us certain things about the body. So say for example, somebody comes in with coughing and high fever and all these signs of infection, and I do a CBC on you, and your white blood cells are 20K, 20,000. Remember, the normal range is between 5 and 10K, but now you're up to 20K. Well, that lab work just tells me that there's something going on with you, and I need to what? Investigate. I need to figure out what it is. Rule in this, rule out that. Well, it's not this, but it could be that. So similarly, when we're talking about this particular drug, right? They're just giving you different reasons why somebody might be receiving this drug. It could be because someone is postmenopausal, right? But it can also be because they're on these drugs, glucocorticoids, right? Remember, you have women who, after menopause, it can cause osteoporosis. So you
Right.
can use it for that. You can use it for if somebody, man up, a woman who's on this drug, and what it leads to a decreased absorption of calcium, meaning osteoporosis. It could be due to that. Or osteoporosis can be due to that. It can also be due to cancer, the cancer destroying the bones itself, right? So just don't get in a kind of a tunnel vision where you're thinking that it's only for women who are postmenopausal. No, that's not what it said here. That's not what it said here. We're getting into other reasons why someone may develop osteoporosis. All right.
Dr. Weaver,
Mm-hmm.
every woman, not all women that go through menopause is going to end up with osteoporosis. Is that correct?
I don't know well, I don't know. Obviously, I don't know everybody, but I would be very shocked if no woman goes through osteoporosis. Some may go through it at a whole lot faster rate than others. Some may not because of maybe their activities. Perhaps, they know enough about it, especially if you are kind of how can I say it? A well-to-do person who understands health very well, and you're exercising, you're taking your calcium, your vitamin D, and so forth. So they may not experience it. Whereas though somebody who's of a lower socioeconomic status, they might experience it even the more because they don't know about take more calcium, vitamin D, and exercise, and this and that. But I think in terms of normally the effects of aging, I would be surprised if no one develops it. The question is at what rate?
So, and you also said that well, you could prevent it by like exercising, eating healthier, um,
Yeah,
things like that.
what are you eating? What are you eating is the question. That calcium and the vitamin D.
Yeah. Okay.
And and you may especially need to increase that amount if somebody's on glucocorticoids because they may be on glucocorticoids for another disease condition. Remember, we give steroids for various conditions.
Right.
Right, because the glucocorticoids reduce how the body absorbs calcium.
Yeah, exactly, which can affect men and women, right?
Yeah.
Right.
Okay.
Although this is a little confusing, it talks about osteoporosis in postmenopausal men and women. I mean, do men go into menopause? I mean, I guess they go into some kind of something similar, but
Yeah, it's not the same though.
no, no. But I'm curious about that, just the way they worded it
The,
here.
the way they worded it, like if you didn't know better, you would think that men go through menopause too.
Yeah, let's see. I don't think I've ever heard of that. I know they go through some changes. Do men go through? Oh, I say post menopause. I know I'm spelling that wrong.
So the main disorders of this chapter would be arthritis, Paget's disease, gout, Crohn's, RA, correct?
Well, this chapter is mainly about musculoskeletal conditions,
Correct.
but it did throw in there. See, this is when you guys got to expand your mind more and don't be thinking that just because the drug is being used for one thing, that it doesn't cause problems somewhere else.
Right.
And so, for example, when it talked about we're still talking about osteoporosis, even though we may be talking about cancer, it still goes back to osteoporosis. So somebody has a cancer that has metastasized to the bone. We're now talking about a musculoskeletal rather, or skeletal condition. So it all goes back to skeletal. So it says men do not go through menopause in the same way that women do, but they can experience a condition often referred to as andropause or late onset hypogonadism.
In the
Hypogonadism.
backpack.
Yeah. So androgens, I guess, so menal would be women and andropause being men. So yeah, so it's not this. So maybe the author should have kind of worded that a little differently, like menopause and you know andropause for men. So, but they didn't do that. But now we know.
Right.
But yeah, so I want you to just keep in mind we're still talking about musculoskeletal conditions, but these drugs they also it's like you have to make connections. We can talk about cancer and how does that connect to or how does that relate to cancer, right? We're talking about musculoskeletal and what have you. But
Mhm.
if somebody develops cancer, cancer can affect muscles and bones as well. So again, we still are talking about musculoskeletal. All right. In other words, the body systems don't reside in a vacuum, so to
Right.
speak.
So
Right.
this is like somebody going to their provider and just saying, they have these symptoms, they get tested for osteoporosis, and then it comes back, oh, by the way, like you said earlier, Dr. Weaver, oh, by the way, you do have breast cancer.
Exactly.
Yeah.
That it doesn't. It's interdependent. One system affects another, and it. I mean, it'd be nice if somebody developed, let's say, colon cancer that is confined just to colon, but we know it spreads to what? Liver and maybe the stomach and other adjacent organs. So we just have to think beyond. All right. In other words, I don't want you to get here when we're talking about malignant disease,
Mhm.
right? And forget the fact that we are still referring to the
Muscle.
bones and how it affects the bones.
That's it.
So, does that make more sense, Miss Joan Baptiste?
It does.
Baptiste.
Hmm. Um, so what did I say here? So bone resorption is like a cleanup crew for bones. Osteoclasts are the cells that break down old or damaged bone and release important minerals like calcium back into the body where they can be used elsewhere. So the body does use that calcium elsewhere. Anyway, I just put that there. Let's see, what else? What else is in this category? So we have your bisphosphonates. Uh, let's
Uh,
see.
the uric
The
acid.
uric acid for gout.
Oh yeah, yeah. So we're talking about gout now. All right. So here again, it's important to understand what is gout, right? So gout is a type of arthritis in which the uric acid accumulates in increased amounts in the blood. So these patients have an increased amount of the uric acid, which will eventually develop into crystals, which gets deposited into your joints. So here I talk about gout as a type of arthritis in which uric acid accumulates in large amounts in the blood and is deposited in the joints. Gout. So the deposit or collection of urate crystals, this is what the uric acid eventually turns to, is urate crystals. They're crystals. And they get deposited into the joints. And when these crystals are deposited in the joints, look what they cause: pain, redness, swelling, and joint deformity. Now, which part of the body do they really get dumped into mostly?
Uh, into the
Which
blood.
which joint in particular?
The synovial joint.
The big toe,
The
Oh,
big toe, the
Yeah,
grand toe, grand toe.
the great
okay.
toe. Well, yeah, great toe.
Great
I'm sorry.
toe.
Yeah, the great toe. Now, so
Okay.
allopurinol is one of those drugs, right?
Mm-hmm.
Okay. Especially the
You guys have heard of this before.
Yeah.
So this drug reduces the production of uric acid. And if I can reduce the production of uric acid, I'll thereby reduce the this
Acid.
urate crystals, and I'll also decrease the amount of this substance being deposited into the joints. So reduces the production of uric acid, thereby decreasing serum uric acid levels, which is in the blood, the serum, the blood. I'm decreasing, right, the serum acid levels. I'm also decreasing the deposit of urate crystals in the joint. Does that make sense?
Yes.
All right, because uric acid is a problem, and it's accumulating in the blood, the serum of blood. But if I and then it gets deposited into the lost joint, especially the great toe, and this is what causes the inflammation. But I'm going to decrease uric acid. Probably some of these drugs causes excretion of uric acid in the urine, so it doesn't build up in the blood, right? All right, so this probably accounts for its ability to relieve the severe pain of acute gout. So this is how it becomes a pain medication in a sense, because if I can decrease the amount of uric acid in the blood, thereby decreasing the amount of, excuse me, y'all. Um, sorry, y'all. Fly was in here. And then I decrease the amount of uric acid that gets deposited into the joints. Then I get what? Less inflammation, right? I get less inflammation. That's what it's all about. Now, so this probably accounts for its ability to relieve severe pain of acute gout because I don't get that much, in my joints. So this is one of the newer drugs. Um, you have allopurinol, but you also have this boxostat, Ulrich. It's used to reduce serum uric acid levels, again, which prevents gout. Now, the exact mechanism of action of colchicine is unknown. Sometimes we just don't know. Let me highlight that one too. All right. Sometimes we just don't know the mechanism of action, even though your objectives say know the actions or the mode of action or whatever. Sometimes we don't know. All right. So just keep that in mind. So the exact mechanism of action is not known, but it does reduce the inflammation associated with deposit of urate crystals in the joints. So it prevents the deposit of these urate crystals.
So all three of them you can use interchangeably?
Well, you can use either of those. I guess it just depends on physician's preference and whatnot, and
Okay.
insurance and all that.
Okay.
So colchicine has no effect on uric acid metabolism. Let's see. I just want to look up here for a minute. So allopurinol reduces the production of uric acid, decreasing serum uric acid levels and deposits of urate crystals in the joint. So you know that particular action for that drug. For the other one, it reduces serum. It's not very specific, and probably because they don't know why. But this particular drug reduces serum uric acid levels as well. Colchicine reduces inflammation associated with the deposit of crystals in the joint. An IV pegloticase or probenecid reduce uric acid levels in the body. So they all are reducing the uric acid levels. Except this one, colchicine reduces inflammation associated with deposits. So this is after the deposit of the uric acid. So, but they all are basically reducing the uric acid
So
levels.
the colchicine is after the flare up.
That's what it seems. So in people with gout, the serum uric acid levels is usually elevated, which makes sense. In an attack, this pegloticase, which is an IV, may be used to decrease the amount of uric acid in the body. So this appears to decrease the uric acid level as well.
Wow, gout can get so bad you need it as an IV?
But remember they said in what?
Acute cases.
In acute cases. So in acute cases, sometimes we need something a whole lot faster. All right. We need something a whole lot faster. So it's not unusual that some drug therapies may be given IV in the immediate acute period just to calm everything down, get things under control, especially pain. This is just one of them. Now, the probenecid works in the same manner and may be given alone or with colchicine as combination therapy when there are frequent recurrent attacks of gout. So sometimes they may give them together in combination. Probenecid also has been used to prolong the plasma levels of penicillin and cephalosporins. See, now we jump to something else. This particular drug, look what it's also used for. Because remember, the longer I can keep penicillin in my system, the better it is able to fight infection. So it's given for another reason. You all see that?
Yes.
So, that sometimes books, I guess, kind of seem to be all over the place. But I guess on the other hand, it's nice to know if we're talking about just nice to know information. I guess that's kind of nice to know. Let's see. So
I'm
drugs.
glad Kayla picked this one.
Say again.
I'm glad Kayla picked this chapter because I really forgot that this one was, yeah.
Yeah, because like when I tell you all the other chapters, I got that down packed. But this one, I've been reading this one for the past 2 weeks, and I am just like I was still confused. I was like, I'm not understanding what I'm doing wrong. Like I was watching videos, note cards, flashcards on my whiteboard.
Well,
I was like, you know what? I quit.
so the disconnect for you might be because you got to know about the disease process and then put the drugs with it. So now
Right.
we know what gout is, uric acid, right? Forming into crystals, deposited into joints. Now we know what it is. and then we think about the drugs associated with it, it's like,
Right,
oh, well,
right,
yeah, well, that makes sense.
right. Because now when we break it down like we've been doing it, it makes sense.
Hmm. So I don't know if you guys hear Mr. Peoples talk sometimes when he says that I was studying these drugs and then I had to go and study the disease process at the same time, or back and forth. We are still doing it. We just did it. We just talked about gout and what it
Right.
is. It's a brief overview, but then when we start talking about the drugs, which is our main topic of discussion here, uh, it makes sense. But he's probably just going back doing a little more reading about it and you have to because you're going to be tested on the med surge at some point. And so it does help to kind of put them together quickly, see what it's all about, and then continue on with your pharmacology because you have to know why these drugs are being administered, why they're being used.
Hmm.
Let's see, so drugs indicated for treatment of gout may be used to manage acute attacks of gout or in preventing acute attacks of gout. So in other words, this drug can be used prophylactically as well. They probably are using the allopurinol as a prophylactic drug therapy.
Yeah, when I looked on ChatGPT, the alpurinol was the main drug for gout. They were
Mhm.
using.
Yeah, I've always heard patients being prescribed allopurinol. All right. So what do you guys think about this? The actions of all these drugs. What do you think about them?
Uh, well, for the gout, seems like
What is it
they
basically doing? Just keep it simple.
Reducing pain,
It's
reducing the
reducing inflammation.
It's
inflammation, and
But what
pain.
but what is the
and
drug
it's basically
doing?
reducing the
it's
production
reducing
of the
the
uric acid.
uric acid.
Yes.
Right.
Yes.
Mm-hmm.
Yes, that's what I need. That's why I needed you all to go because the uric acid is the problem, right?
Right.
And these drugs are preventing the accumulation, the production thereof of uric acid, helping us to either get rid of it in some way or fashion, which leads to reduction in pain. It doesn't directly reduce pain. It reduces the uric acid that when it accumulates and get inside those joints and brings about, what did I say?
Pain and inflammation and swelling.
Right here.
Oh, the uric acids. What you
This
mean?
this is what the uric acid is doing.
Yeah.
But think about it. If I head off the uric acid, will it lead to this?
Mm-hmm.
Yeah.
No, it won't lead to it because I'm reducing the uric acid that's causing the problem. I'm
Right.
focused on the problem now. Make sense?
And then the teachings would be on what we're eating and drinking because we know this alcohol is one with uric acid, and then certain foods like I think we said red meat one time we were
The
reading.
purine foods that
Yeah,
increase.
purine food. Yeah,
Yeah. And you'll see that in the nursing process, which is why you need to read about the nursing process.
right.
It should speak to that.
Mm-hmm.
So you got to think about that diet too when it comes to rheumatoid arthritis.
Yeah, yeah, yeah. Oh yes.
You know, I'm not sure to see what this is 22. I'll look at it real quickly, but all right. So this is your adverse reactions, uric acid. Let's see, uric acid. All right, so now we see, so we covered the drugs that you guys found to be difficult.
Yep.
And the same way with what I just did, this is how you all should be approaching this information. So as a kind of a model, I'm modeling for you how we do it.
But even with reading, like Kayla said, even with reading and her doing the extras that she was doing, hearing us talk about it was more helpful also because she could not get it the way she was reading and putting it together. So I definitely didn't even recognize some of it, but now I understand it better.
And that's why
Yeah.
even getting in groups, have group studying sessions where y'all can talk this out can also be beneficial. That's not to say that we can't Zoom, we can do that too. But in the interim period, don't hesitate to develop these groups. I mean, strong groups can really be developed. I
Yeah.
was trying to look to see. All right, so let me show you guys this real quickly, just in case you are, let's see, what diet is important out. Uh,
I read something, I don't remember where it was. Cherry juice was good.
um, cherry juice. I know cherry. I remember cherry, but I'm trying to remember if it's good or bad.
Yeah, I saw cherry juice was good.
Let me see what this says because I know diet is a big part of this. I'm thinking Perrine Foods or something.
Yeah, it did say Perrine.
That and you can't eat scallops and things like that too.
All right, all right. I was looking for it in the nursing process. So dietary guidelines for
What's that?
prevention.
Organ meats. Ooh,
So,
wee.
so this is what you would encourage. Now let's look at what you can eat. Foods to limit or avoid high purine foods, red meat, organ meats, shellfish and oily fish,
Mm-mm.
game meats. Somebody mentioned alcohol, sugary drinks, refined carbohydrates. So yeah, really important.
That red meat right there.
Yep.
What organ meats? Liver? Oh my God, I used to eat that so many years ago.
Somebody said scallops, didn't they? Somebody said scallops.
Mussels and scallops. Yeah, I'm gonna get scallop.
Mhm. Yeah. So if you have, let's see. I thought some of these drugs actually help to excrete the uric acid in the urine, but I didn't seem to come across that. Let me see what else it says. Encourage liberal fluid intake and measure the intake and output. Consider IV fluids. Uh, GI, maintain upright. Let's see. Clients must remain upright. Option. See, clients on bed rest. See, these are the things that you really have to be concerned about. Assist with ambulatory activities if drowsiness does occur, because they fall and it's easy for them to break bones with weak bones, osteoporosis. Clients on bed rest need to be turned every 2 hours. All right. Monitor the client being with gout being treated with IV pegloticase closely for development of adverse reactions. All right. Yep, we know that. Um,
Adequate fluid.
yeah, adequate fluid intake. Um, when using drugs for muscle spasms and cramping, explain that the drug can cause drowsiness and to avoid driving or doing hazardous tasks. We talked about that already. The drug is for short-term use. Advise a patient not to take the medication longer than 2 to 3 weeks. That's important. And of course, you don't want to mix it with alcohol or other CNS depressants. The methotrexate, teach the client family to use a calendar or other memory aid to remember to take the drug on the same day every week. That's important. Childbearing age to use method. Let's see. So tell the patient of childbearing age to use contraceptive therapy with methotrexate, and for 8 weeks after therapy. Let's see, teach the client to drink 10 glasses of water. So this will actually help to excrete the uric
Urine.
acid.
Yeah.
Avoid driving, the plumbing. Let's see, during gout, tell the physician. All right. I thought it would give me a little more. Yeah, make sure you guys are reading this.
Take the drug rising in the morning.
Yeah. Huh. I'm curious about something.
It said, remain upright. Don't lie down when you're taking the methotrexate.
Yeah, that one was an important one as well. Sitting up for a certain period of time. I was trying to think of the
30 minutes
reason.
after you take the drug.
Yeah, yeah. That's something they could test you on, actually. Let's see. Some gout medications do promote excretion of uric acid in the urine. The drugs are called uricosuric agents, and they help lower the uric acid levels in the blood by increasing its elimination through the kidneys. So the urosuric drugs promote uric acid excretion. We looked at this one. The probenecid inhibits the reabsorption of uric acid in the renal tubules, so it stays in the urine, increases urinary excretion of uric acid. Most effective in patients with yeah, whatever. All right. I thought some of these did that. So uricosuric agents like probenecid increase the excretion of uric acid in the urine, making them useful for certain gout patients. All right. However, proper kidney function and hydration are key to avoiding complications like kidney stones. Also, keep in mind that when people have gout, they can develop renal stone because the uric acid forms into crystals, which can form into stones. So you know how when you have kidney stones, they tell you to strain the urine, and they can actually examine or analyze those stones and discover that they are uric acid. And so in other words, they may be able to tell that this patient has gout as well, or can lead to gout.
What was that test? I forgot who said it. I don't know if it was somebody said with the test. Dextrose was the test.
Now, what do they say now?
What was the test somebody had said?
The test?
Are you talking
Yeah.
about the bone density test?
Disco scan.
What
I think
said
it was a DEXA scan.
Disco.
Dextrose?
Yeah.
It may be spelled another way. Um, but yeah, it's just basically a scan that they use to assess for osteoporosis. Yeah, it's a DEXA scan, dual energy X-ray absorptionmetry,
Mhm.
absorptiometry, also called a bone density scan. It's non-invasive. It's also called it measures bone mineral density. It's the gold standard for diagnosing osteoporosis and assessing fracture risk.
Gold
So,
standard.
so the less dense your bones are, the more susceptible you are to fractures and osteoporosis. Given to women 65, who should get the scan? Women 65 plus or men 70 plus. So men should also think about this as well. All right. So what else you all have?
I think So for this exam, we got the non-opioids, the
That's like,
salicylates and non-salicylates, that's okay. Non-steroidal, the NSAIDs and the migraine headaches, that's okay. Upper and lower respiratory drugs. I think the most difficult one was the one we just went over.
I think so too. I think so too. They're kind of funny, and in a way, but until you really break them down and go through them, then you see that it's not as hard as, first glance, if you will.
Right.
Dr. Weaver,
Hmm.
you know that wall that you're always talking about that we build up, and I don't even think we know we do it. But like prior to coming to this group tonight, I guess I had a wall built up because I could not break through on this chapter. But then like hearing you talk about it and hearing my classmates talk about it, it just seemed like it just bust wide open for me.
Yeah,
Here
yeah.
comes-
Because it's doing something very simple. It's doing some really simple things like the DMARDs, right? We're just trying to weaken, not weaken, but weaken the immune system so it doesn't destroy the body. Those antibodies, those autoimmune conditions are destroying bone tissue, joints, and what have you. And we're just telling the immune system, hey, slow it down, partner. You're doing too much.
Yeah, it
You
makes
know,
a lot of sense now.
the muscle relaxants. We've come to understand that this is not working directly on the muscles, but it's causing a more of a sedative like effect, causing the person to be more relaxed. You know, and thereby causing muscle relaxation, which means decreased pain. They all seem to decrease pain indirectly when you think about it.
So what you said was, I mean, tell me if I'm right or wrong, I'm sure you will, but the medications that are prescribed for like safe gout is not prescribed for like pain relief. It's more so prescribed to inhibit the uric acid
Which is what's
buildup.
causing pain.
Right.
Right.
So if you take care of that, then you relieve the pain.
Take it out of the equation.
Okay.
That's the main thing, that the main issue, that's mainly what's contributing to the pain.
Makes sense now.
You know,
Same thing with the DMARS. You weaken the immune system.
so you have
decrease
less attack,
pain. Mhm.
less attack from the immune system. The immune system and that attack and the inflammation is bringing, that's what's causing the pain. But now I'm going to slow you down. I'm going to suppress you. I'm going to calm you down and tell you to stop doing so much.
Which is why the relactants, one of their adverse is the drowsiness because it's slowing you down.
It's
So does
more,
it work as a sedative?
yeah,
The
it's
rel-
more of a depressant.
Hmm.
It's a more depressant effect. Yeah, yeah, I would say too that is probably the one that can give people some problems. So hopefully this thing will allow me to send this to everyone so that they can look at it again, because they probably gonna need it.
Hmm.
Yeah, I think you did a voiceover on this one too.
No, not on 29.
You sure?
Hmm.
It seemed like I thought, because I don't remember actually going over this.
Yeah, there's one on 29.
Is
When
it?
did he
Look
do
up
it?
today. Yeah.
When
It's
did he do it?
I don't know when he did it, but I know it's on there now.
Wait a minute. So,
Yeah, it's on the I mean 29 is the skeletal muscle bones and joint disorders, and that's what the voiceover is on.
but is that drugs or med surge?
It's on pharmacology.
What, you looking at it?
Yeah, it's week 7. And if you go down to pharmacology, the last chapter on there is 29. It gives you the PowerPoint and then it goes into the voiceover.
That's why I didn't remember.
Yeah.
Well, you mean tell me y'all wasting my time talking about this stuff?
It's not wasting your time because this goes, now you're going into more detail about it.
Oh no, no, trust me. Let me tell you something. What in the heck?
So we have a fraction.
Wait a minute.
What do you think we need to do?
That's not it. So, okay.
Well, in this problem, we could start by subtracting both sides by 3, just as we
What I'm saying is, guys,
He supplied, he didn't do a voiceover.
Huh?
reactions. We know that.
Yeah.
Oh, yeah.
What I'm saying to you
see it.
guys, when I do voiceovers, I'm actually taking my time even the more because I don't have all the distractions, people in and out of classrooms, people talking, doing this and that. I can put a whole lot more focus on this thing, which is I'm sure is what I did. And
Yeah,
so,
because you were saying in the video that you had started doing it, but like you got pulled out for like a meeting or something.
well, this one I definitely did.
Well as the uric acid crystal in the joints is what actually causes the symptoms of the pain and swelling.
Yeah, so if I were you guys, if you're still kind of feeling iffy about it, I would definitely go back and look at that. I have heard, as I've told you guys already, that people said that they don't listen to the voiceovers, but you really don't know what you're missing, because I really take a lot of time to go through the material, again, because I don't have all the distractions. And so you would benefit greatly if you took the time to do it. I'm not telling you to sit down and listen to it all. You shouldn't have to listen to it all. In fact, this one is only an hour and what, 12 minutes?
Yeah.
That's not long, y'all. I mean, come on. You can sit down for a moment. That's good training. Try to get out of your feelings. That if I don't like it, I'm not going to do it. Well,
Right.
God darn, if that's the case, I don't like to go to work all the time.
Right.
And if I use the same thought process, guess what? Where's Professor Weaver? Isn't he supposed to be here? Yeah, but he didn't feel like coming because he just didn't feel it today. So sometimes we got to press over how we're feeling because we don't want to just sit there and focus and listen. That's actually good training for you to learn how to listen. It's a good attribute to develop. Testing and training your listening and comprehension skills. Do I have the ability to listen to someone say something and really focus, really concentrate? All the readings that I've done over the years and a lot of the training that I have done, for example, when Miss Tanya was talking about the calcium and the cancer, and I heard what she was saying, and I was able to correct it because I have the ability in most cases. Sometimes, I'm a space cadet. I'm just thinking about all kind of things, but you'd be surprised at things that just goes to my mind. But in this case, I was able to hear what she said, and I didn't just sit there and say, "Oh yeah, 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 that's right, that's right, that's right," because then she'd go away thinking that this is what it is.
Causes cancer, leads to cancer.
Exactly. And I'm saying, no, 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 no. It doesn't lead to cancer, right? I was able to correct that because it allows me I have the ability to listen and to understand what someone is saying. Sometimes, depending on how it's being explained or how I'm receiving it, I mean, the communication breakdown can come from both ways. I mean, who knows, right? We all got a lot going on. But you really should give yourself a chance because see, here's what you're doing. You're probably maybe you're reading, let's say, chapter 29. Miss Barkey said that she at least was reading it and she did this and she did that. I don't know if she knew whether or not a PowerPoint existed, but a PowerPoint does exist, and that should have been listened to first Then you come to me and say, I still don't get it.
Mhm.
And I'll be honest with you. Had I known that I did this voiceover, I would not have discussed it today.
Yeah,
I would have told you guys, give me something else. Because I'm doing all this work and then it's being ignored. And so you cannot expect to get it, to receive it, to understand it, if you don't at least give yourself a chance.
right.
I'm not on here just talking randomly, doing these voiceovers randomly. I'm very intentional with what I'm doing. I'm trying to explain it to you just like if I was in class.
Dr. Beaver, do you believe that like in person and even with Zoom presentations that a person gains more from having that interaction versus just doing it on their own? I mean, yeah, you can do it on your own and you can gain understanding, but sometimes for me personally, it works better like if I hear you talking about it or if I'm in class.
See, that's a block you probably put in your mind because if you think about it, I'm short of you being able to ask me in real time, well, what about this? What about that? You could still give yourself an opportunity to go through, let's say, this particular voiceover, and
Mhm.
then when if it generates still questions, when you come to class, you could say, well, I heard your voiceover, which is what I would love to hear. So, Professor Weaver, I heard that voiceover and you said something about that uric acid thing. And for some reason, it's just still not registering. Then at least I know that you put some effort into it and you won't be totally lost. You understand? So, the only difference is, you know, you listening to it on your own and versus being in class is that we can get some clarification in real time.
Mhm.
But it doesn't mean that if we never had this Zoom, it doesn't mean that if you had listened to the voiceover that it wouldn't have been beneficial to you. It would have been beneficial, but you just have to give it a shot. You
Yeah.
know, um, a lot of students they like the voiceovers, and let me explain to you guys why I do the voiceovers. If we got a lot of material to cover, if I try to cover all that material in class, I'm going to burn through it. I'm going to burn through it. And you know what? You're still going to sit up there and look at me kind of crazy. So what I'm trying to do is I'm saying, all right, so I'll take this difficult topic and we'll discuss this in class, and I'll take something else and I'll do that as a voiceover. That way I can take my time with the information that we're going over in class to teach you guys how to think through that information. And that's what I'm trying to do. I'm trying to get you guys to think through that information. I'm trying to model that behavior.
Yeah.
See, you have to understand um, my methods, you know, um, how I'm deliberately and intentionally just trying to help you to think about this thing. If you just really sit there long enough, be patient with yourself, and you listen, you get more out of it than you realize. It's like I told you earlier, don't depend on somebody to always give you the information. That's why when you guys asked me that question, what were we talking about? The osteoporosis and the glucocorticoids. Y'all asked me a question and I flipped it right back on you. I highlighted that thing and I said, you tell me.
Right. Dr. Weaver,
Hmm.
I did not know you had a voiceover, but thank you. I'm gonna go listen to it again. But
And yeah,
um,
and tell me what you think.
yeah, I'm gonna listen to it as I'm driving. Um, also for just to ask a question and I'll look through. Do we have a voiceover for lower and upper respiratory drugs?
That I'm not sure about. You have to look at the
The
hopefully
link,
you guys are what was that?
I'm just look back in the link because I'm looking at the syllabus, the syllabi right now. So I'm looking at week 13, 14, 15, and 29. So 29 is the only one I see that you have a voiceover for based on that screen that you have up front now.
Well, this is week 7.
7. So
And
I'm
the
gonna
only
look,
thing we
I'm gonna
have
look,
is, what is this one?
so I'm gonna look for week 8 and 9. See if
What is,
you
oh, so this is the one for pain. I didn't want to have no discussion with you all on this particular chapter, so I didn't do that one. But so let's see, week 8,
we
and
gonna have.
see,
Mhm.
this is also probably one of the reasons why I kind of cut down on some of
So
this stuff that I was
the one
doing.
that you just clicked on right then, that was 10.
Well, this is 8 here, so that this one doesn't have one. Um,
The one you were talking about for pain.
uh, which one was that one?
You just said you opened something for pain.
Was that 7? No, I think that was 7.
That was week 7, right?
Yeah, that's 7.
And so that was 15, had a voiceover. No, that's 10.
That's chapter 10.
Yeah, that's med search.
Yeah, that's med surge too, though.
Oh,
Which you could benefit from, but it's up to you.
I see. That's message.
So that's
Okay.
8 and 9.
So now there was no voiceover in week 8. So now week 9,
Well, that's chapter 31.
that's med surge.
That's lower respiratory, but
Mhm,
that's
that's
med surge,
right. That's lower though
lower, and there's nothing
in farm.
for farm.
And then this week right here, we have the exam, so week 10. So I'm gonna listen to 29 and then in the med surge for pain, and I'm gonna listen to the one we just said. So I'm listen to those driving
Well, this one you don't have to worry about because that's on the
on the final.
yeah.
Yeah.
And see, I don't think some people are really well, I mean they could, but I guess sometimes we forget because we're doing it so much.
I did forget that there was a voiceover there.
Yeah. Why is this double? It's a double week 6 for some reason. Well, I did that. All right. What else do you guys have?
I think that's it. I think I'm good. I'm just gonna listen to these 2 voiceovers. I'm gonna listen to those 2 voiceovers you have for med surge. And go.
Uh, I did have something, Dr. Weaver, so just give me 1 second. Let me get to my chapter here.
If you all don't mind, and I don't know what your time is like, but if you had time to listen to the voiceover on the musculoskeletal drugs that we just went over, I would love to see what your thinking is around it now. And let me say this to you. Yeah, it's what was it, an hour and 12 minutes, was it?
Yeah.
You know,
Now,
it's on a YouTube platform, meaning you can speed it up slightly, and you could probably be finished with it in about 40 minutes. I said that plenty of times in class. So, um, that was here in chapter 7, or rather week 7. So if you open up YouTube,
oh yeah, I know now.
I think it's settings.
The breakdown of the no happy.
Y'all see where it says playback speed?
Yeah.
That's normal. If I click on that,
again, it can
that's normal, but I can go like this.
To dangerously high numbers, which can lead to strokes, severe headaches, and other in organ problems. Because
See how fast that went?
Extreme high blood pressure.
Yeah.
And so you go to settings and check out how it sounds here.
Affect perfusion to our organs and as well as our tissues. I'm sorry, everyone. And also just to make sure you take.
Can you all hear this?
Medications,
Yes.
Yeah, I can hear it.
You see how fast that is, right?
Yeah. I don't
Or
need
I
to
can
go
take
that fast.
I can take it
When
real
I'm driving,
slow.
I don't need to go fast.
See how slow I'm moving now?
Yeah.
So this is normal.
All right, that's
I'm
good.
gonna put it on when I start driving.
Also,
Maybe 1.25.
meaning they can be given, but we just have to
Yeah.
be cautious.
Or
Dr.
maybe
Weaver,
not. You know, you may just want to listen to it at the normal pace. But that's the ability you guys have. It don't have to be an hour and a half. It could be maybe 45 minutes.
I'm driving 2 hours, so I'm good.
Yeah.
Dr. Weaver,
Mm-hmm.
you asked if we had any more questions. I did want to ask you briefly about hopefully I can say it right. The nitroglycerin for chapter 35.
Mm-hmm.
There are, I believe, four different routes in which you can give it. And I was just trying to figure out, like, is there a particular route that you take for um like are the routes particular to like a certain symptom or
They're buccal or sublingual, right?
well, yeah, I mean they're you have the oral ones which is the buccal and sublingual. Then you have the ointment, you have the transdermal. I'm clear on that one.
Right.
Um I just wanted to know like is it up to the doctors like whatever he thinks should be given? I know it's whatever he thinks should be given. I'm trying to think of a way to word this. There's
Well,
four ways to give it, but I guess I'm asking like is there certain situations where you would give one over the other?
for example, obviously, if you were at home, you're thinking about the sublingual one or the buccal one because
Okay.
you're at home.
Right.
But you can also be at home or in the hospital, and we just put the patch on you. It's
Okay.
just a part of your regular,
Right.
medications, a regimen. If we're talking about like IV stuff, it's probably because you're in the hospital and you have an acute condition going on, like pulmonary edema, maybe chest pain, a heart attack, or what have you. Then you'll likely be on something IV, you know. And of course, also in the home, we may give you the drugs, PO, some drug that causes vasodilation, like calcium channel blocker, that can cause vasodilation as well. And so it just really depends.
Okay.
But emergency situations, especially out of the hospital, would typically involve, the what do
The
you call
oral
it? The
buccal
sublingual, the
or
little tablet,
sublingual?
Uh-huh.
right? Or the buccal type. It just depends.
Okay.
But just think IV acute. Something's acute going on.
Yeah.
Okay.
The bigger
Well,
things you have to worry about with that drug is that even though it causes vasodilation so that you can get better blood flow to your tissues and organs, well,
right.
in particular to your heart, in this case, not tissues and organs, but to your heart.
Yeah.
And so I'm trying to open up those blood vessels so I can get more blood flow, and that way the pain goes away.
Hmm.
The pain is there because of ischemia. You got
Right.
decrease in blood flow to that to the heart muscle, if you will. And you're worried about side effects, especially like hypotension, because if it causes the blood vessels to dilate, then it causes your blood pressure to drop,
Yes.
if that makes sense.
Yeah, there was one question that I seen, and this is, it's not verbatim, but it was just simply asking, what would you monitor for, like pretty much if you're gonna give the nitroglyceride, I think I said it right, or the nitroglycerin, if the person has a intracranial pressure,
Yeah,
uh,
you
to
got to
also
be intracranial bleed or increased intracranial pressure.
so if a person has that,
Monitor blood pressure,
right,
Well, you got to be you got
heart
to be
rate, heart
careful.
rhythm.
You got to be careful with that though, because if you take a nitro
hmm
and it dilates the blood vessels that brings blood to your brain,
Brain.
it can cause even more increased intracranial pressure.
Yeah.
Why? because you're increasing the blood flow to the brain. Remember those three components of intracranial pressure:
Mhm.
blood, cerebrospinal fluid, and brain tissue.
Sure.
Yeah.
Mhm.
So remember, there's that Kelly Monroe doctrine where I said that each of them, all three of them, they have to be in some kind of fluctuation of sorts in order to maintain that 5 to 15 intracranial pressure. And if one gets out of whack, then the other two has to adjust in order to keep those numbers still within normal limits. So if you take this drug, you're going to increase the blood flow to your brain
Mhm.
more than what should be there. And that is also going to cause your intracranial pressure to increase.
Increase. And
And
that's, I guess that's what my question was about. If you're going to give that medication, then you're definitely going to be monitoring the ICP to make sure that pressure is not increasing.
Yeah.
But uh, I can't remember, but how do you monitor that?
Remember I talked about the EVD drain, it's what do you call it? It's see, is this it? It's an EVD drain, and basically they put this. You have to remember when I was talking about the neurological system, and they put this device in your ventricles. It can be in your, I think, this the subarachnoid space, in different spaces, and it can read the pressure in your brain. I even showed you all in class this device. It's called
Yeah.
it's an EVD drain, and this is external ventricular drain, and they insert it in your skull, and they're able to get readings of your ICP.
Okay.
All
So
right.
if you already have an ICP, um, would they already be monitoring that and you're just kind of looking at the machine to see what the pressure looks like?
You're
Or
always monitoring the machine. If
okay,
the patient requires that, you're always monitoring it, because if it goes up and it's sustained, say if it goes up to from normal to 20 and it's
yeah,
sustained, what you're doing is putting pressure on those blood vessels in the brain. If you're putting pressure on the blood vessels in the brain, how you going to get blood flow through those how are you going to get blood flow through those through the cerebral vasculature, the brain's blood vessels? Because I'm what's that word, obliterate, like, for example, if somebody was to take your radial artery and they were to press into it deeply, what do you think your hand is going to feel like after a while?
tingly,
Yeah.
there's no blood flows getting to it.
That's because you don't have any blood flow through it. So the same thing is happening in your brain. That the reason why intracranial pressure is so important is because when it gets too high, that pressure in the brain is just pressing on those blood vessels. It's obliterating the blood vessels, and you can't get blood can't flow through the brain.
Which causes like confusion, and then wouldn't that cause like you to like you wouldn't have enough oxygen in your brain if there's not enough blood flow?
You can have a stroke,
So
anoxia, no oxygen, brain tissue would die. It would become more inflamed. And if it becomes more inflamed, your intracranial pressure would do what?
go up. So
Go up.
would you at that point notify the health provider, of course, but would you hold that medication until you heard back from the healthcare provider?
Well, I would likely do that if I understood the mechanism of action around that, because if I'm an ICU nurse and they're supposed to know these things, but we're supposed to know a whole lot of things we don't. But if I'm an ICU nurse and I have a patient who has a brain injury with an EVD, they have an EVD device in place, and I see that the ICP is, let's say, 17, which is above normal, slightly above normal, and I have to give this nitroglycerin. I'm going to get on the phone and say, "Hey, doc, this patient's ICP is already 17. Oh, now I just went up to 18, and I got to give this vasodilating drug.
Mhm.
What do we do? And
Okay.
what they'll probably tell you to do is to let more CSF out because you're draining the CSF to control the ICP.
Mm.
Okay, I was just, Dr. Weaver, I'm just gonna ask one question, then I'm gonna get off because I gotta get on the road.
Yeah.
From
Wait a minute,
you,
y'all. Before you say that, you see this right here? You'll see some cerebrospinal fluid in this device. And as
Mhm.
you raise it, you decrease drainage from the brain. And if you lower it, you decrease the amount. And so,
Does it matter how much? I mean, is there a specific amount you get? So, like you said, 17. We know the range is 5 to 15.
5 to
So,
15.
right. So if it's that much over, like, what is that? Two.
That's two over. But so I haven't done these in a while, but I will have to see what the parameters say. See if the parameters say keep ICP because they know that you can't keep the patient's ICP normal because of the extent of the injury. So the
Right.
doc could say keep it below 17.
Okay.
That won't cause as much problems as if somebody went up to like 20 and above or so.
Oh
That
gosh.
can really cause some problems.
Now you said you said blood, interstitial fluid, and something else.
No, I said blood, cerebrospinal fluid,
Cerebral
and
spinal.
brain
I thought you
tissue.
said interstitial. I was like, why did you say that? Okay.
I never said that.
I know that's why I was saying I think I interpreted what you said that way.
Uh-huh.
So those,
Cerebral fluid.
so those are the three I don't know how to say it, but the three things that are on the brain, which is the blood, the CFS fluid, and the brain tissue.
Yes. And
But you termed it something.
all right, I want you all to see this.
Okay.
What contributes to the ICP? I need to do this out of
I know it's what contributes, but how did you term it when you said it? You said the three something.
basically I said the what contributes to the intracranial pressure, not increase or decrease, just the fact that what makes up or what creates pressure within the brain, the skull, oh please, uh, is is blood, the brain tissue itself, because it takes up so much space, blood as well as cerebrospinal fluid. All of these contribute to the intracranial pressure. If there's an increase in any of these, it is going to raise your intracranial pressure, such as brain tissue swelling. That will raise your intracranial pressure.
Which
If
makes
somebody
sense.
has a hematoma in the brain, meaning you're bleeding in the brain, that's going to increase your intracranial pressure. If you're producing too much cerebrospinal fluid in the brain and the excess amount is not being drained away, it is going to cause an increase in intracranial pressure. If there isn't an increase in brain a swelling or whatnot, we'll just take off the CSF. We don't usually take off blood, but we do take off CSF, that device that I just showed you.
Right.
Use this device to take off the excess amount, and that will hopefully lower the amount, lower the ICP,
Okay.
right? Because the ICP is not lower, it's going to destroy the brain tissue. And what I was telling you all about is the Monroe-Kelly doctrine.
Yeah, that's what you said.
Monroe Kelly Doctor.
It explains that the skull is a closed compartment. You know, the skull, it doesn't flex. It's not flexible. It's the cranial vault. It's stationary. It's fixed, right? If the brain swells, the skull doesn't go with it. It stays the same, but then the brain keeps swelling and putting more pressure on the brain, and that's a problem.
Is that why when somebody has like a stroke or something, they may remove part of the skull so that
in
the
order to allow it to expand. So where it talks about here, so an increase in one component, any of these components, must be compensated by a decrease in another, in another. In other words, if there's an increase in brain tissue, there has to be a decrease in these two. Or else the ICP is going to rise.
okay.
And again, if it rises, just think if I keep putting pressure on your blood vessels in your brain, blood has to come from the heart, is pumped from the heart through the jugular vein, artery, and up of those veins that or the blood vessels that carries blood to your brain and circulate in your brain. But
Mhm.
if all this pressure is increasing and I put pressure on those blood vessels, blood is not going to be able to circulate through the brain. And now you got to be asking yourself, well, why is that a problem? Because
Because we have
blood
a pump.
brings glucose, oxygen, nutrients, and all those things. Well, if the blood vessels are compressed, I can't get those items. I can't get the oxygen and the nutrients and so forth, the glucose. And your brain is going to die as a result.
All
Okay.
right, guys, I gotta get off. I gotta get on the road. I thank you. You guys, thank you so much, Dr. Weaver.
All right. By the way, real quickly, I might have you guys coming in next, or maybe the next couple of weeks or so for class. Have the farm being done in the morning from 7 to 10. But shoot me an email to let me know if you're against it. I'll be sending an email out just to see. But I talked to Professor, rather Miss Davis.
Where we
Uh,
in week 10?
I got to look at it. Well, tomorrow we'll be on, not tomorrow, Tuesday we'll be on campus for farm anyway because you all have the exam, so that's not a problem. But
Yeah,
probably 11 and 12. If we're lecturing, I'll probably have you coming in a little early, maybe at least at one time, just so I can see how you all do. Because
right.
people are saying if we have farm first and then med surge, it would be better. So I want to
The
see.
med surge gives us the basis for what we need to know for farm. That doesn't make sense, but I'm cool with whatever we do.
Yeah. Well, what they're saying is by the time after lunch and you giving me this complex subject like
Oh,
porn, I don't like it. And I'm tired, probably eating a big meal, whatever the case is. So they're saying that they think if they come in fresh, that they'll do better. But I wish I had done it. I wish I had known that the director, she always tells me to come to her office and talk to her, and I should have done that. But she happened to be outside the other day when I was leaving, and I mentioned it to her, and she said, "You can flip it if you want to." It's like, oh, so I should have done it.
well, you didn't know, so
Well,
now
so I don't realize how much autonomy I guess I have, but if people, I mean, if you guys feel that, hey, I think I'll do better if we have farm in the morning. Because what I like about that is you get to then do med surge from 10 until 11:50, get that break, and then come back after lunch and finish it up.
yeah.
So if we come in the morning, we'll do med surge from what time to what, I mean, farm from what time to what time?
So be 7 to 10. So you get out of there and you can go home at 10 o'clock in the morning.
I'm okay with it. Like I told you in the classroom, I'm okay with what everybody decides. I'm one person and the class is what 18, 20 deep. So
I mean, unless that conflicts with your current schedule, I mean, I won't do it.
I don't have a schedule. I just come for miss for farm.
Yeah, but can you see the advantage of you being able to, I don't know about, because I know you text me sometimes and you say,
The
this,
traffic.
this traffic is crazy.
Yeah, the traffic is crazier after the morning.
Yeah, if it was me, and I'm not just saying this, I'm just saying if I was only coming to one class, I would prefer to beat all the traffic.
Yeah.
Mornings, of course, you have to kind of fight that a little, but that's probably not a big deal for you if you're coming from, let's say, Georgia, and it takes you a while to get. to Jacksonville anyway, you're probably leaving about 4 o'clock in the morning
Mm-hmm.
or whatever time that is. So anyway, so I'll send an email and just maybe look at my schedule and see what we got left.
All righty.
All right, folks.
Thank you,
All
Dr.
right. Thank you
All
so
right.
much. And I'll see you guys this week.
All right.
All right. Bye-bye.